this plan has been going back decades, which is now seems to be accelerating and reaching its end game. So I'm not really going to mince my words. And then in a kind of cruel twist of irony, after publishing the book, I found myself as a patient on the receiving end with a life-threatening diagnosis, and I had several months of treatment back in 2015, 2016. So thanks to the NHS, I'm still here. So I've seen it really from both sides. My story really, or the story I've tried to outline, begins in the 80s with the first outsourcing. So what we saw then was, under the Thatcher government, the beginnings of outsourcing NHS services to the private sector. And that started with things like catering, cleaning, laundry, as you're probably familiar. I'm sure some of you have longer memories than I do. But the first big step, I would say, was from 1990 onwards with the introduction of something called an internal market. And what you will have to get used to, unfortunately, with all of this is a lot of rather abstract, technical, euphemistic terms, which is designed really to bamboozle you, I'm afraid, because of some of the interests that are behind this program. So the internal market was really just a limited market introduced into the NHS, dividing the NHS up into trusts. And that was really from 1990 onwards, based on the idea that competition would improve healthcare services or public services. And it's interesting that Thelma's just talked about, or someone just mentioned, evidence-based policy. That would be really lovely. What I've actually been told by a former civil servant in the Department of Health is they actually have a term for this, which is policy-based evidence-making. And it's funny, but it's true. It's sadly true, I'm afraid. So these are the actual terms that are used. That and another term, which is lines for the media. So that's another term inside the Department of Health, is how to just present something to the media, or really to the public sphere, in a particular way in order to sell it. And we'll see there's a lot more of that. So really what I'm driving at here is that this is obviously much bigger than just the NHS. This applies to everything, I think, in our society, which is an economic, it's a political orthodoxy, ideology about the fact that everything should be run by deregulated free markets. And that means not just the NHS, it means transport, infrastructure, education, public services. And I think we've seen that that's been pretty disastrous in most of those spheres. We're talking about not just cuts and reducing funding, we're talking about privatisation, we're talking about deregulating private companies in the free market, we're talking about deunionisation, financialisation particularly, you'll see in housing in the NHS, which is turning things which used to be social goods into basically financial instruments for, really a kind of a global class of investors. So from following that first step, the Department of Health actually commissioned at least one study into this, which found that introducing a limited market didn't improve services. It actually escalated costs significantly by about 10%, if you're talking about administrative costs. And so that cost of just introducing a limited market is something estimated to be between about 4.5 up to potentially £10 billion a year. And that's because you start to, once you divide everything up into lots of different trusts, you start to fragment things, you generate a lot more bureaucracy, a lot more administrative staff and managers needed to manage all of this. And that goes against everything we're told. We're told that obviously bringing in the likes of Richard Branson or bringing in Virgin, bringing in private companies is meant to increase efficiency, reduce costs. And in fact, when you look at all the international evidence, it's the opposite. It's not just here, it's in countries like Germany, Canada, and particularly the US, where you see that the costs shoot up, partly because you increase all of this administration and bureaucracy, ironically, through market forces, but also because you start to have to deliver profits for shareholders. So it becomes a kind of a wealth extraction process. Now, despite knowing this, what we saw from 2000 onwards was expanding that market inside the NHS. So if we were following evidence-based policy making, you would have reversed that step, because the Department of Health and other interests already knew that it was a more inefficient, expensive process. But in fact, they went in the opposite direction from 2000 onwards, sadly, and they introduced public-private partnerships, particularly, and I think you'll be familiar with them here because of the story with the HRI, and the fact that, well, we'll come on to some of that, but basically closing down services, hospitals, selling off permanently, of course, NHS estate and land, and instead replacing it with PFI or public-private partnerships. So when that market was expanded, it wasn't just about PFI, it was about expanding outsourcing to clinical services, so bringing in private companies as permanent providers of all kinds of clinical services, including GP services, out-of-hours services, particularly imaging, so diagnostics like MRIs, etc. But of course, PFI really, which was about, was the biggest legacy, I think, of that period from 2000 onwards of expanding the market. And PFI, for those who aren't too familiar with it, is perfidious financial idiocy. No, it's private financial initiatives. And that consisted of consortia of corporations of companies. So you had banks, financial companies bringing in kind of private investment, private financing, you had construction firms building hospitals, and you had other companies delivering what's called facilities management, so hard and soft services in hospitals, such as maintenance, repair, but also all kinds of other services that you use in a hospital. So that was what PFI was. This was something that it wasn't that politicians woke up one day and thought, I know, we'll just finance everything privately through banks, and then it'll be actually owned effectively by some of those corporate interests with the profits going offshore. This was something that was lobbied for. This is the kind of hidden story of PFI that we don't hear a lot about. We hear quite a bit about Carillion now. There's been a lot of people like myself trying to bang on about PFI for a while. Of course, right now you can't kind of buy the publicity, the bad publicity it's getting with Carillion, Capita, Interserve, all of these contractors who have either collapsed in the case of Carillion or are in a lot of trouble. But actually what you don't hear is some of the even more powerful interests behind that, the big banks, and that's where PFI really originated. And I won't be able to go on and on because I won't stop, but this was a story that originated in the City of London with the likes of Barclays, RBS, HSBC, and in fact one of the reasons Carillion collapsed was the interest rates it was paying those big banks. So they've been really some of the biggest winners. And so over 100 hospitals, but also schools, transport, so roads, railways, prisons, all of that was built with PFI. PFI Hospitals was the biggest part of it. The result is that for hospitals that should have cost, if they'd been publicly financed, the kind of good old way, should have cost about £11 billion to build over 100 new NHS hospitals. That's going to end up costing up to potentially £80 billion. And if you're talking about the whole of the UK's PFI debt, it's over £300 billion is what every single one of you and every single person in the country, really every single adult, is paying in taxes to those interests. And a lot of that goes offshore. So kind of ironically, the building upgrades for the Treasury, for the tax office, for HMRC, were PFI upgrades, and the company that did that is based in Bermuda. So you couldn't really make some of this stuff up, really. So HMRC's own PFI upgrade is based offshore for tax avoidance purposes. So it's not accidental, any of this. So that was PFI. I'll probably move on because I think some of what's happening now is more important, actually. PFI's disastrous legacy is going to be with us for a long time unless we resolve it and we start thinking about some of the solutions that, for example, I think it's only John McDonnell's been taking on the most actually progressive solution, but we'll come to solutions, I think, later. From 2010 onwards, we've seen an acceleration under the coalition government and then the Conservatives, an acceleration of this process of privatisation. So the big reform was something called the Health and Social Care Act, 2012, which came into effect actually about 5 years ago, so 2013. Now, that's over 400 pages. I can't kind of really do it justice. I'll try and just sum up 3 or 4 of the key points. The first thing it did in legal terms, legislative terms, is it basically axed the government's responsibility to provide a comprehensive health service, and it devolved that responsibility to, as you've heard, bodies like NHS England, so Quangos, and of course all the CCGs, the clinical commissioning groups up and down the country. So those were the first two things it did. The third thing it did, which has probably received the most publicity, is it opened up NHS contracts extensively to outsourcing, so to really privatisation. So there had been, of course, outsourcing before of clinical services, but this really expanded it. We've seen the numbers on that basically double. So since 2010, the figure for private sector NHS outsourcing has gone from about 4 billion to, 4 to 5 billion up to now, at least going back to 2015-16, we haven't got any more recent figures, I don't think. It's about 9 billion, approaching 9 billion now. So that's doubled, but it's early days. So that was really kind of putting CCGs, for example, between a rock and a hard place, where they and other bodies are forced to tender out contracts for risk of litigation. We've seen that already happen. We've seen Virgin, for example, being paid fairly recently by the NHS because it threatened litigation over one of these contracts. And we've seen some really big contracts, actually, kind of for multi-billion pound deals being tendered. Some of those haven't been won by the private sector, some of them collapsed, of course. Some have been won by some of these big multinationals. The fourth thing that the Act did, you might have to give me a kind of, I don't know how long I've got left, but a 5-minute warning or whatever. 5 minutes. I shouldn't have said that. The fourth thing it did, which I'll very quickly cover, is it allowed hospitals, foundation trust hospitals, to make up to half their income from private patients. So previously there was a cap for how much hospitals could make from private patients, which was 2%. That cap was lifted up to 49%. So that's a hell of a hike, isn't it? So that's up to nearly half is basically what hospitals can now make up to from private patients. And if you look at the big world famous centres, especially where I'm based in London, but across the country, they're really kind of capitalising on that. I'm going to quickly spend the last few minutes just focusing on the present, so 2015 onwards, and certainly since the books come out, events, dear boy events, as Harold Macmillan used to say, have really overtaken. So we've obviously had 2 general elections, Brexit, the junior doctors strike, and quite a lot more in the Corbyn phenomenon as well. So what's happening now is really an attempt to consolidate all of this, and Paul's already mentioned the this US model of accountable or integrated care. And I think it's very important to really understand that, because that is what the government is pushing through right now. And as I said, that's imported from the US, and I really don't think that a US model of healthcare is what we want to be bringing over here. It's one of the most, actually, it's pretty much the most iniquitous and retrograde healthcare model amongst advanced economies and countries. It is not a model that we would want to be emulating. But in fact, Jeremy Hunt specifically cites the Kaiser model, which is Kaiser Permanente is a US-based, California-based organisation. And Simon Stevens, whom you probably haven't heard of, I would guess, because when I ask NHS staff even, you tend to draw a blank. He's head of NHS England. He spent 10 years working as a senior executive for United Health, which is the biggest private healthcare and insurance company in the States, and in fact the biggest in the world now. So they've been very influential, and he's come back, really. He was Blair's advisor, went off to work for 10 years for United Health, and has come back now to run the NHS, and he's importing this US model. So this is, obviously not what, this is what we need to be fighting against. But accountable care in a nutshell, as Paul's mentioned, is about having first what they call accountable or integrated care systems, and ultimately heading towards an ACO, an accountable or integrated care organisation, which would mean one organisation running your health and social care services, so including budgets but also delivery of services. And because the government has been trying to sneak this through without legislation, without parliamentary scrutiny, until these judicial reviews have been called, it would have meant that you would potentially have non-statutory, non-NHS bodies running your health and social care services. So there would be nothing to stop a private healthcare company or an insurance company running the whole of health and social care in an area, say like, I don't know, West Yorkshire or any part of the country. And as if to kind of underline this, we've already seen in Nottingham and Nottinghamshire a nearly £3 million contract awarded to Capita and the UK arm of a US health insurance company called Centene to bring about that transition. So that's really what is happening right now. So when you hear, I've heard a lot of people say, oh, NHS privatisation, that's a conspiracy theory. It's not a conspiracy. Well, it is a conspiracy in some ways, but it's happening right now. It's not theoretical at all. And the other aspect of integrated care, how it dovetails very briefly with all of this, is it very much merges with all the cuts, the closures, and so on. So what you're trying to do as part of privatisation is really to shrink the public estate and to ramp up private healthcare and infrastructure. And you do that, of course, through cuts and closures firstly. So we now know that there are tens of NHS trusts, so something like over 60 NHS hospitals and trusts, according to the Daily Telegraph, for example, facing or have already experienced closures, downgrades, mergers. NHS England previously announced it wanted to reduce the number of major A&Es for the whole of England down to between 40 and 70. They've put that plan apparently on the back burner, but that was their explicit statement previously. They would like to now reduce the number of GP surgeries from 7,500 to 1,500 of these super hubs. They've also announced through the Dalton Review plans to create what are called super hospitals, which is why they want to really close down district general hospitals, cottage hospitals, small hospitals, and why they also want to close down your traditional family model of general practice and these smaller GP surgeries, single-handed surgeries. And you're creating, from the point of view of the corporate and financial elite, you're creating economies of scale, because that is much more profitable. If you're Virgin, if you're Serco, if you're United Health, you want to take over a chain of hospitals or a chain of GP surgeries. So I absolutely can't kind of underline enough how important it is for you to keep fighting these cuts and closures, because they will try and sell this as improving care, or we can't provide this care because of cuts, etc. But actually, that's really the bigger picture for me. And so this is the end game stage we're in, and hopefully in the discussion we can talk about solutions and kind of more positive things. Okay, thank you.